everybody. Dr. Daniel here. And today I'm talking about concussion and migraine. Well, in the old days, like 1971, when I was a neurology resident at the Mayo Clinic, concussion was pretty simple. It was explained to me then as a head injury associated with brief loss of consciousness. Loss of consciousness usually meant being out cold 3 or 4 minutes. A longer period of time being unconscious could be something more serious, like a cerebral contusion, which means a bruise of the brain, a skull fracture, or the development of a blood clot in the head, like a subdural or epidural hematoma. For workup, then, we could only do a skull X-ray and EEG. Early on in my medical school training, but in my freshman year of residency at the Mayo Clinic in 1971, Mayo developed the first CAT scanner in America. Later, CAT scan use spread across emergency rooms, so by the mid-70s, CAT scans could be done in emergency rooms all across America, evaluating persons from either a motor vehicle accident or sports-related injury causing brief loss of consciousness from concussion. Later, MRI scan was developed, and that shows more precise interior brain damage and anatomy than CT, but the chief question for the emergency room physician when he sees a head injury in the ER is, does this patient have blood in the head? And CT shows blood in the head better than MRI scan and does it quickly and reliably. CAT scanning analysis for a head injury is now standard in American ER departments, but in some patients who get follow-up MRI scans, that'll show more microbleeds and linear brain lesions. Migraine is a genetically inherited common medical problem involving the release of inflammatory chemicals in the brain that inflame the trigeminal nerve, the cerebral arteries, and the thalamus. Trauma from concussion can aggravate migraine headache intensity and frequency. Concussion and migraine are clinical diagnoses, and medical testing is usually normal. So, concussion and migraine are common post-head injury problems, but with time there's been a change in the meaning of concussion, and migraine is better understood as it occurs with a patient with a brain that's sensitive to stress, light, sound, odors, fasting, falling estrogen levels, insomnia, and traumatic brain injury. So that a concussion occurring in a patient with migraine often results in more severe headache because of this special brain that's involved. As time has gone on, descriptive adjectives have been added to the word concussion to objectify it, such as a slight, mild, or a severe concussion. These adjectives are subjective and relate to perceived severity of the blow and the duration of time the patient is unconscious. Mild concussion results in short-term neurologic dysfunction that resolves spontaneously in 7 to 10 days. A small percentage of patients with concussion have symptoms that can be longer-lasting and disabling, and this is called post-concussion syndrome. Nowadays, concussion is considered to sometimes occur with no consciousness. An example would be a football quarterback who received a head injury but can still carry on with normal function, such as receiving the ball or passing it okay, but on sideline interview with a trainer is found to be confused and to not know the date or the name of the opposing team. They call it, he had his bell rung. This would be like a light concussion, while the player who has sustained a severe tackle and hits the ground with his head may be completely out cold and unconscious on the ground for several minutes and have to be removed from the field on a stretcher. Some concussions cause loss of consciousness, but most do not. It's possible to have a concussion and not realize it. 10% of concussions are associated with loss of consciousness or brief seconds of blackout. The concussion blow to the sensitive brain of a migraine patient releases inherent brain neurochemicals, which can result in severe migraine headache, which can be short-term, such as the day of the head injury, or longer lasting, such as migraine headaches that last for a long time. Many post-concussed migraine patients overtreat with painkillers, caffeine, triptans, opioids, or butalbital. Taking these drugs frequently can cause daily severe migraine-type headaches along with nausea, vomiting, sensitivity to light and sound. According to the data compiled by the National Hospital Ambulatory Medical Care Survey, the incidence in the United States of minor head injury was 503 per 100,000 population out of 1,367 visits per year to the hospital emergency departments. Depending on the definition used, the population examined, approximately 50% of patients with minor head injury have symptoms of post-concussion syndrome at 1 month, and 15% have symptoms at a year. The number of patients who sustain minor head injury and do not present for medical care is unknown. Therefore, the number of patients with post-concussion syndrome is likely underdiagnosed. The International Classification of Headache has a term called persistent headache attributed to traumatic injury to the head, and that's described as a headache of more than 3 months' duration caused by a traumatic injury to the head. The diagnostic criteria are traumatic injury to the head has occurred. Headache is reported to have developed within the 7 days after one of the following: the injury to the head, regaining of consciousness following the injury to the head, discontinuation medications, impairing ability to sense or report headache following the injury to the head. Headache persists for over 3 months after its onset, and it's not accounted for by another headache diagnosis. Traumatic injury to the head is defined as a structural or functional injury resulting from the action of external forces upon the head. These include impact between the head and an object, penetration of the head by a foreign body, forces generated from blasts or explosions, and other forces yet to be defined. When the headache following head injury becomes persistent, the possibility of medication over use headache needs to be considered by the doctor. Related items. There's a thing called second impact syndrome. There's a second head injury. If there's a second head injury within 24 hours to 10 days after the initial concussion, there's an increased risk of having second impact syndrome. This may cause massive brain edema with brainstem herniation and death or severe disability. It's fear of this syndrome that limits return of an athlete to active play after certain periods of time. Traumatic brain injury and chronic traumatic encephalopathy. The advent of the discovery of repeated mild or severe concussions and worse head injuries such as contusions has led to the current world of TBI or traumatic brain injury, where repeated traumatic cerebral events can lead to dementia and psychiatric mood changes called CTE or chronic traumatic encephalopathy, which has its own pathology and neurologic abnormalities. A definition of concussion. Concussion in lay terms can mean a bump, collision, crash, impact, impingement, jar, jolt, jounce, kick, shock, slam, smash, strike, or wallop. It comes from the late Middle Age English, Latin, concussio, from the verb which means to dash together or shake, and con, which means shake together, so it means shake together, what it means. Cerebral metabolism. The brain is precious soft tissue placed inside the skull into compartments of the frontal lobes, temporal lobes, and occipital and parietal lobes. It's sort of like pieces of chocolate that are placed in small paper slots in a box. Then the brain is wrapped with a dura mater, which is a plastic-like material, like a steak wrapped in plastic at the grocery store. Underneath the dura, spinal fluid shields the brain and protects it from trauma. When there is head trauma, there's some movement of the brain within the skull so that there can be frontal head injury, a contrapute injury to the back part of the brain, as the mechanical gravitational forces from frontal head trauma proceeds to press the brain against the opposite side of the skull, the so-called contrapute injury. The brain has the consistency of gelatin, is cushioned from injury by sterile spinal fluid inside the skull. A violent blow to the head and neck or upper body can cause the brain to move against the inner walls of the skull. Sudden acceleration or deacceleration of the head caused by events such as a car crash or being violently shaken also can cause brain injury. These injuries affect brain function, usually for a brief period, resulting in signs and symptoms of concussion. This type of brain injury may lead to bleeding in or around the brain, causing symptoms such as prolonged drowsiness and confusion. These symptoms may develop immediately or later. The brain is made of billions of neurons carrying electrical and chemical information, which, with acute trauma, shuts off suddenly, like pulling the cord on a Christmas tree light. The patient suddenly becomes unconscious and will stay so for either seconds, several seconds, or sometimes several minutes. The pathology of a concussion. It's not clear. There's a disruption of cell membranes and channels for sodium, calcium, and potassium function, leading to a loss of normal neuronal activity. This can cause mitochondrial dysfunction, resulting in failure and loss of energy and normal glucose metabolism. But because people don't die, they don't have their brain examined, they're not pathologically examined, it's hard to know the pathology of concussion. The duration of amnesia. Later, when the patient awakens, there may be no memory for the time the patient was unconscious, and awareness should return shortly after regaining consciousness. However, some patients may have memory loss dating to before the time of the head injury, and this is called retrograde amnesia. It is thought that the severity of cerebral trauma may relate to the duration of time of retrograde amnesia. A loss of memory for a week before a head injury is more serious than someone who can remember everything up to the moment of impact in a car wreck. Neurologic testing for concussion. Brain metabolic function is supplied by arteries, which bring fresh, oxygenated blood in, and veins, which take away metabolic products. A brainwave test, or an EEG or electroencephalogram, done during the time of a concussion is abnormal with slow brain waves, but by definition, CT or MRI scans should be normal. So the anatomy on scanning is normal, but the electrophysiology that's detected by the EEG is abnormal. With a concussion, after the patient regains consciousness, there may be short duration of confusion, but nothing severe. And usually after several minutes, the patient will be awarded normally again. More severe head injuries may be associated with non-arousal in a patient in coma due to cerebral contusion, bruising of the brain, or a subdural or epidural hematoma. Neurologic symptoms following a concussion. The immediate symptoms could be headache or feeling of pressure in the head, temporary loss of consciousness, confusion or feeling as if in a fog, amnesia surrounding the traumatic event, dizziness or seeing stars, ringing in the ears, nausea, vomiting, slurred speech, delayed response to questions, appearing dazed, fatigue, post-concussion vertigo, an epileptic seizure. Post-concussion syndrome with delayed symptoms hours or days after injury could be concentration and memory complaints, irritability and other personality changes, sensitivity to light and noise, sleep disturbances, psychological adjustment problems and depression, disorders of taste and smell, vertigo or dizziness. Symptoms in children. Head trauma, unfortunately, is very common in young children, but concussions can be difficult to recognize in infants and toddlers because they can't describe how they feel. Concussion clues may include the child appearing dazed, listless, and tiring easily, irritability and crankiness, loss of balance and unsteady walking, crying excessively, change in eating or sleeping patterns, lack of interest in favorite toys, and vomiting. The incidence of concussion. A study from Columbia University of 1,203 athletes found 23% of women and 17% of men had at least one concussion during their college days. The American Medical Society for Sports Medicine has estimated that 1 to 1.8 million sports-related concussions occur per year in patients younger than 18 years old. This organization defined concussion as, quote, a traumatically induced transient disturbance of brain function, period, end of quote. American Academy of Neurology states that each year 1.63 part 8 million concussions result from sports recreation injuries in the United States. Almost 9% of all U.S. high school sports involves concussions. Most concussions result in full recovery. However, some can lead to more severe injuries if not treated early and properly. Risk factors. Activities and factors that may increase the risk of a concussion include falling, especially in older folks and young children, participating in high-risk sports such as football, hockey, soccer, rugby, boxing, or other contact sport. Concussions can occur in many sports. Concussions are common in high-speed contact sports. Football, rugby, hockey, and soccer have the greatest risk. Baseball, softball, volleyball, and gymnastics involve the least risk. Gender varies from sport to sport, but there may be evidence that concussion risk and soccer and basketball is greater than in females and in males. Specific risk factors here: participating in high-risk sports without proper safety equipment and supervision, being involved in a motor vehicle collision, being involved in a pedestrian or bicycle accident, being a soldier involved in combat, being a victim of physical abuse, having had a previous concussion, having migraine, and having had the APOE4 gene, which gives a risk of memory problems after head injury. Medical advice regarding return of activity. American Medical Society consensus guidelines endorse 24 to 48 hours of symptom-limited cognitive and physical rest, followed by a gradual increase in activity. They stated that the large majority, that is, 80 to 90% of concussed older adolescents and adults, return to pre-injury levels of function within 2 weeks, but in younger athletes, clinical recovery may take up to 4 weeks. Good sleep hygiene is also important to help the athlete recover. It's stated that a return to sports activities should follow a successful return to classroom activities. A stepwise increase in physical demands or activity without symptoms is important before the patient is able to participate in full contact play. It's no longer recommended the patient have long periods of time of lack of cognitive or sports involvement, such as weeks or months. But the patient should never return to play or vigorous activity while signs or symptoms of a concussion are present. An athlete with a suspected concussion should not return to play until he or she has been medically evaluated by a healthcare professional trained in evaluating and managing concussions. The patient should be cleared for play by a licensed healthcare professional, and if there's problems, consider this rule. If in doubt, sit it out. So, concussion is worse in persons who have migraine, but it can also be severe in patients who've had tension-type headache, although that's not a severe problem. The doctor and the patient should always watch for and avoid medication overuse headache, which is a monster problem in patients with head injury who are given a lot of medicines, particularly opiate narcotics in ICU and later in hospital and discharged on opiate narcotic of some sort. In general, if you take International Classification of Headache, it said if you take butalbital, opiate narcotics, or triptans, 10 tablets a month, that can lead into medication-overuse headache. If you use simple over-the-counter drugs like caffeine, Tylenol, Advil, NSAIDs, one pill 15 days a month, that can lead into medication-overuse headaches. We need to avoid that. So the take-home advice here is post-concussion syndrome has indistinct borders of limit of time patients may be affected, especially in the older literature. Many of these patients had a simple concussion and were overtreated for causing medication-overuse headache. Previous migraine patients and latent migraine patients may have more headache after concussion. These patients should limit analgesic use after head injury. I use the term latent migraine to refer to the commonly occurring new patient with daily headaches following a previous mild concussion who was a normal workup and scanning and no significant headache prior to the head injury, but may have had previously subtle, mild links to migraine in their story. Some of these latent migraine post-concussed patients may have had close relatives with migraine. They may have had motion sickness, which has a 60% link to migraine, or previous mild but not very severe hungry headaches, sinus headaches treated with Sudafed, or menstrual headaches. Patients and doctors should be instructed to limit medication treatment for post-concussion patients. So I hope these thoughts and words are helpful to you. Please click on subscribe down there so we can follow each other. Thank you for listening to this, and I'll see you again on the next talk.